Hello, welcome to our talk on pathology of soft tissue tumors. This is meant to serve as an overview to your reading in Robbins. A brief outline of where we're headed today. We'll start out with just a brief overview of some basic concepts about soft tissue tumors, and then we'll move on to talking about tumors of specific types of tissue, so fatty tissue, fibrous tissue, skeletal muscle, blood vessels, nerves, and finally we'll touch on a tumor that doesn't quite fit into any of these categories. So what is soft tissue? Soft tissue is essentially any tissue in the body that is not epithelial, not bone, brain, lymph node, or hematopoietic cells. So if you think about what is left, we're essentially dealing with muscle, we're dealing with fibrous tissue, blood vessels, kind of all the stuff in between the bone and the organs. So general concepts in soft tissue tumor pathology, the benign tumors are actually much more common than malignant tumors. And we call any malignant tumor that arises from these mesenchymal cells a sarcoma, right? So as opposed to a carcinoma, which is a malignancy that comes from epithelial cells. In general, if you have a patient who presents with a superficial tumor, just underneath the skin, for example, those are much more likely to be benign than tumors that are deep within the thigh or deep inside the abdominal cavity or the retroperitoneum. So the other general principle is that sarcomas tend to metastasize via blood vessels, so hematogenously, and this is different from carcinomas, which usually metastasize through the lymphatics and into the lymph nodes. Although more research has found that there's actually a lot of connections between the lymphatics and blood vessels, so this may not be a set in stone kind of thing. So some more basic principles about soft tissue tumors. The majority of sarcomas actually are sporadic, meaning that they are not inherited. It's thought that they arise from these pluripotent stem cells, which then acquire some somatic mutations which drive them towards neoplasia. A small minority are associated with inherited mutations in tumor suppressor genes, which we'll be talking about, like neurofibromatosis type 1 associated with neurofibromas. And the majority of sarcomas in younger patients tend to have a simpler karyotype with very few chromosomal changes. And an example of that is Ewing sarcoma, which we'll be talking about more when we talk about bone pathology. And sarcomas, which happen in adults, tend to have a more complex karyotype, so they tend to be aneuploid tumors with genomic instability. And they also look more pleomorphic to us under the microscope. Some more basics about classification of these soft tissue tumors. So tumors that arise, this is just a cross-section of the leg and about mid-thigh level. So here we're looking at fat underneath the skin, and tumors that arise from fat, when they are benign, we call them lipomas. When they're malignant, we call them liposarcomas. Anything that I have in green here is something we're going to talk more about. The things that have been left in black, we are not going to be discussing in this talk. So then we can have tumors that arise from fibrous connective tissue. They can be reactive proliferations, which are really not neoplasms, things like myositis ossificans, or they can be benign proliferations, which we'll be talking more about, like nodular fasciitis, superficial fibromatoses. Then there is this lesion of sort of unpredictable biological behavior, meaning that it is sort of locally invasive but tends to not metastasize. We call that a deep fibromatosis or a desmoid tumor. And finally, you can have malignancies arising from fibrous tissue, but these are relatively rare. Then we have skeletal muscle tumors. Benign tumors of skeletal muscle are called rhabdomyomas. You can see them in patients with tuberous sclerosis, but the majority of skeletal muscle tumors that happen in children are actually malignant, and we call them rhabdomyosarcomas. We'll be talking about that shortly. The other types of smooth muscle tumors or other types of soft tissue tumors include tumors of smooth muscle, and we discussed a little bit about these in the reproductive course. You learned about leiomyomas in the uterus and leiomyosarcomas in the uterus. They can also happen outside the uterus in just soft tissue or in the dermis, and it's thought that in these locations they happen from the erector pili muscles or maybe the smooth muscle around blood vessels. Then we have tumors of vessels. When they're benign, we call them hemangiomas. There is this kind of intermediate sort of neoplasm called Kaposi sarcoma, and true invasive and aggressive malignancies of vessels are called angiosarcomas. We have tumors that come from nerves, specifically peripheral nerve sheath tumors. When they're benign, we call them either schwannomas or neurofibromas. And when they're malignant, we call them malignant peripheral nerve sheath tumors. And finally, there are some tumors that just don't fit into one of these categories, either based on what they look like to us under the microscope, based on the proteins. We can stain for proteins for these different types of lineages, or based on molecular markers. So a tumor that doesn't fit into any of these other categories in an adult is often called an undifferentiated pleomorphic sarcoma. And in the past, this used to be called an MFH, a malignant fibrous histiocytoma. So we'll briefly touch on that at the end of the talk. Some more general principles: benign tumors tend to be non-invasive by definition, and they do not metastasize. Malignant tumors tend to invade and infiltrate into surrounding tissue, and they have the capacity to spread from where they originate to a distant site in the body. In general, benign things tend to be nicely circumscribed. They are often encapsulated, versus malignant tumors, sarcomas, tend to be poorly circumscribed and infiltrative. Benign tumors tend to be better differentiated. Malignant tumors could be well differentiated, but they are often poorly differentiated. Benign tumors tend to not be very cellular and often don't have necrosis or hemorrhage. And malignant tumors are the opposite of those. Cytologically, benign tumors tend to look very bland and uniform with very low nuclear to cytoplasmic ratios, versus malignant things look ugly. Mitosis usually is low in benign tumors and high in malignant tumors, but we'll look at some exceptions to these rules. So we're going to start out with tumors of fatty tissue. And these are actually the most common types of tumors that you will see in patients in adults. So the most common benign tumor that you see in adults is a lipoma. And here is what it looks like clinically. It's a pretty well circumscribed subcutaneous lesion. It will be very soft when you palpate it, and it's freely mobile, usually painless. And if it gets excised, this is kind of what it looks like on gross pathologic examination. It's kind of yellowish, because tumors of fat are often yellow to us. And when you look at this tumor under the microscope, it looks like lots of mature adipocytes, fatty cells. They do have tiny little nuclei pushed off to the periphery. And the way you know that this is actually a fatty tumor and not just subcutaneous fat is because there's often a capsule around this thing, and the clinician tells us that this was a mass. So completely benign, really no risk of transformation into anything bad for this particular patient. And this is, of course, different from the malignant tumor of fat, which is a liposarcoma. And a liposarcoma is actually a relatively common sarcoma that happens in adults. And unlike the lipoma, which was a superficial tumor, a liposarcoma happens in deep soft tissue and retroperitoneum. So when I was doing my fellowship, I was actually trained that any fatty tumor that comes from the abdominal cavity that's deep is usually a liposarcoma and not a lipoma, even if it doesn't look that bad to us under the microscope. So there are three principal subtypes, which are determined by what they look like under the microscope and based on certain molecular abnormalities. The majority of liposarcomas are well-differentiated liposarcomas. They have a very characteristic abnormality. They have amplification of this MDM2 gene, and MDM2 normally inhibits p53. So this inhibits the tumor suppressor, and that's how it results in adipocytic proliferation. Well-differentiated liposarcomas are the ones that you usually see in the retroperitoneum. The other subtype of liposarcoma is called a myxoid liposarcoma. There is a round cell variant of this. This has a different type of translocation associated with it, and this produces a transcription factor which sort of arrests adipocytic differentiation. So we'll see how this looks a little bit different. And finally, the most rare subtype of liposarcoma is a pleomorphic liposarcoma, which just looks very ugly under the microscope. The prognosis for every sarcoma, and really for all malignancies in the human body, is determined by grade and stage, and of those, stage is more important than grade in general, right? So what it looks like under the microscope is sort of part of the grading of a tumor, and in this case, well-differentiated liposarcomas tend to do better than myxoid tumors, which tend to do better than the pleomorphic ones. So let's see what these kind of look like under the microscope and in the gross examination. This is a paratesticular liposarcoma. This is the testis on cross-section. This is just fat that's around the testis. And in this case, you can see that we have this white, firm mass. This is the liposarcoma that has invaded around the testicular parenchyma. If you looked at this under the microscope, you would see what looks kind of like mature fat, but there's a lot of kind of connective tissue, and we have these large cells with hyperchromatic nuclei, which are actually a weird type of lipoblast, which we see in well-differentiated liposarcoma. Now, this is another example of a liposarcoma, which is showing you the classic lipoblast. A lipoblast essentially is just a cell that has a large, dark nucleus, and it's indented or scalloped by all these fat vacuoles. It used to be thought that lipoblasts are characteristic of liposarcoma, and they are, but now that we have all these genetic molecular tools, we have found lipoblasts in things that are not necessarily liposarcoma. But anyway, well-differentiated liposarcomas have these hyperchromatic nuclei. Pleomorphic liposarcomas look kind of different and ugly, but you can still kind of tell that they're fatty tumors. And then at the bottom here, we're looking at a myxoid liposarcoma, which often happens in the deep tissue of the thigh. If you excised this and looked at it under the microscope, it's called myxoid because it has this bluish sort of mucinous material in the background. Remember, we talked about the fact that this has a translocation that's arresting adipocytic differentiation. So you can see these cells don't really look like nice mature fat cells. These are also lipoblasts. They have this big fat vacuole and a hyperchromatic nucleus. They're associated with this myxoid background. And then the third characteristic of a myxoid liposarcoma are these branching sort of capillary-like blood vessels. So liposarcoma is very common, sarcomas in adults. We're going to move on to talk about some fibrous tumors. So a benign tumor of fibrous tissue is nodular fasciitis. It's a very interesting lesion. It used to be thought that it's just a kind of a proliferation or reactive process, but they actually have found that there is a translocation associated with nodular fasciitis, which involves the myosin chain heavy portion of the myosin gene and this USP6. And so this is a clonal proliferation and a neoplasm. The common clinical presentation is a younger patient who presents with a rapidly growing lesion. It's a solitary mass, often happens in the forearm or trunk, and sometimes there's a history of preceding trauma. The important thing about this tumor is that this history may make you worry that it's something bad because it was rapidly growing. When you remove it, pathologists who may not be familiar with this may misdiagnose it because it looks kind of bad to us under the microscope. So it is a tumor of fibroblasts, and all these spindly nuclei, these are all fibroblasts. Sometimes they call them tissue culture-like fibroblasts because supposedly when you grow them in tissue culture, they kind of have these long processes. There's often some red blood cells that are extravasated out here. You may be able to find mitotic figures in here. So here's an example of a benign lesion that may have lots of mitotic figures in it and therefore can mimic a sarcoma. But the important thing is to know that this is benign. So for the patient, the prognosis is excellent. It usually does not recur, and you don't have to manage this with any kind of wide excision or chemo. So we're going to move on to superficial fibromatosis, which is another benign tumor of fibrous tissue. There are 3 different variants, sort of depending on location. All of these are more common in men than in women. And the first type is a palmar fibromatosis, also called Dupuytren's contracture. In this case, we have these broad, sweeping fascicles of fibroblasts which start in the fascia, and they can kind of adhere to the overlying skin. And this, as it thickens, can cause contractures. So what we're seeing here is this sort of bent appearance, right, of this ring finger, or in this case, a little finger. So it's usually the 4th and 5th fingers of the hand that get bent in this contracture of Dupuytren's. Another variant is when you get these long fascicles in the plantar aspects of the feet, and it is used to be called letter hose disease. Another sort of benign fibromatosis. And then the third variant is called Peyronie's disease. And this is the penile fibromatosis, in which you can actually get abnormal curvature to the penis and constriction of the urethral opening. Next, we're going to talk about this interesting neoplasm. It is a fibrous neoplasm of uncertain biologic behavior. And by that, I mean that it can be very locally aggressive, it can infiltrate, but it usually does not metastasize. So it's not truly malignant, but it can cause a lot of problems locally. And this is a deep fibromatosis, also known as a desmoid tumor. A desmoid tumor can either happen in extra-abdominal tissue, like the shoulder girdle or the pelvic girdle. It can happen on the anterior abdominal wall, and that's more common in women. Or it can occur in an intra-abdominal location. And this is very common in patients with familial adenomatous polyposis syndrome, Gardner syndrome, which is a variant of that. And part of the reason for this is because these tumors are associated with mutations in beta-catenin and the APC gene. And you remember from the GI course that the APC gene is mutated in the FAP syndrome as well, right? And through this mutation, we have increased Wnt pathway signaling, and that promotes tumor formation. So in this gross example, we're looking at the ileum, a resection of the ileum here, and there's this big tumor that is out in the wall, and it's infiltrating into the small intestine. This was actually a desmoid tumor. If we looked at this under the microscope, we would again see these broad sweeping fascicles of spindled fibroblasts, and the starred area out here, this is actually smooth muscle in the wall of the ileum. So you can see, I mean, this is not necessarily a malignant tumor that metastasizes, but it can cause a lot of local problems for your patient. And it can be very hard to resect and therefore may recur. So we're going to move on to talk about rhabdomyosarcomas. These are the most common type of sarcoma in kids. Do you remember the most common type of sarcoma that happens in adults? So you could say liposarcoma. Liposarcomas are common in adults, and the other common type of sarcoma that happens in adults, which we haven't talked about yet, is the undifferentiated pleomorphic sarcoma. But anyway, here we're talking predominantly about the pediatric population. We have 3 different subtypes to rhabdomyosarcomas. The embryonal subtype is the most common, and the botryoid type of embryonal this is just a subtype of embryonal rhabdomyosarcoma, which happens in mucosa-lined structures of the body. So botryoid carcinomas happen in the nasopharynx. They can happen in the vaginal area or the bladder. And they usually happen in kids under 5 or under 10 in this case, and they can happen in the head and neck area. Here we're looking at embryonal rhabdomyosarcoma that happens in the orbit, and on the right-hand side we're looking at a botryoid tumor that was excised, and this is the one that happens in those hollow mucosa-lined organs. And if you looked at this embryonal rhabdomyosarcoma under the microscope, we typically have these primitive cells. Most of these we can't tell that they are truly muscle cells, but sometimes you have what they call strap cells, which are kind of these longer, more striated looking fibers, and these are primitive rhabdomyoblasts, and that can give you a clue that it is in fact a rhabdomyosarcoma. But as a pathologist, when we're not sure, what we do is called immunohistochemistry, where we can stain for certain proteins. So you can stain for desmin and myogenin, which are proteins specific to skeletal muscle, and that can tell you that it is in fact a tumor of skeletal muscle. On the right-hand side of the screen, we're looking at the microscopic appearance of a botryoid tumor. So this is the mucosa of this organ, and underneath here we're looking at the tumor. It's made up of round cells, which they call this a cambium layer. There's sort of condensation of these nuclei, and below it becomes more loose and myxoid, and you can still see these types of rhabdomyoblasts inside here. Okay. And so the next subtype of rhabdomyosarcoma is called the alveolar rhabdomyosarcoma. This is more common in adolescents, so I would say under 20, for example, and it usually happens in the extremities. This one does have a characteristic translocation associated with it. It's this 213 translocation, which results in PAX3 fusing with FOXO1. And then 113 is another translocation, which results in another PAX forkhead translocation. This particular translocation ends up producing a fusion protein, which interferes with normal skeletal muscle differentiation. So notice in the embryonal rhabdomyosarcoma, we still have some cells that look a little bit like rhabdomyoblasts, right? Though that rhabdomyosarcoma doesn't have this weird fusion protein. We're going to see what alveolar rhabdomyosarcoma looks like. It looks different because it has this protein that prevents the cells from differentiating into proper skeletal muscle. And finally, the rarest subtype of rhabdomyosarcoma is a pleomorphic type, usually happens in adults. It's hard to even know that it is of skeletal muscle differentiation because you have these bizarre, ugly-looking cells. And prognostically, the botryoid subtype of embryonal has the best prognosis. It does better than alveolar, which does better than pleomorphic grade-wise. So here is a microscopic appearance of alveolar rhabdomyosarcoma, and the name alveolar actually comes from the fact that this tumor is sort of lobulated by these fibrous septae, and then it has these cells. These are those primitive rhabdomyoblastic cells, which kind of stick to the outside, and then they're discohesive. It falls apart in the center. So it kind of vaguely resembles the alveoli of the lung, and that's why this is called an alveolar rhabdomyosarcoma. But anyway, unlike the embryonal, which had rhabdomyoblasts, alveolar rhabdomyosarcoma is a small round blue cell tumor, and it's because it's got that transcription factor which keeps these cells from differentiating into more mature skeletal muscle. Moving on, we're going to talk about some vascular tumors, and most the more common vascular tumors that you see are hemangiomas. Hemangiomas are very common in young people. Sometimes children are born with them, but you can also develop them later on in life sporadically. So there are different variants. There's capillary hemangiomas, which is what we're looking at here. There are juvenile hemangiomas, which babies are born with, and these can regress. There are cavernous hemangiomas, which are associated with they occur in deeper tissue and are seen in patients with von Hippel-Lindau syndrome. You may remember patients with von Hippel-Lindau syndrome also get these hemangiomas in other organs of the body, like the retina, the cerebellum, the brainstem, and the liver, right? And pyogenic granulomas, this is just a misnomer. This is a subtype of a lobular capillary hemangioma, and that's what we're looking at on the right-hand side of the screen. They can happen in the mucosa, like the oral cavity or the tongue, or they can happen on the extremities, really anywhere on the body, and it forms a nice red mass. It's often ulcerated. And let's see what you're going to see if you look at it under the microscope. It is a pretty well circumscribed proliferation. It's made up of capillary-sized blood vessels. They're lined by a single layer of endothelial cells. And you know that this is blood vessel and not lymphatic because there are red blood cells inside the structure. Okay. Unlike an angiosarcoma, hemangiomas are well circumscribed and they don't really have any endothelial atypia. On the right-hand side of the screen, we're looking at an example of a cavernous hemangioma. It's called cavernous because these vessels are just really big. And they can be a little bit more infiltrative, but it's still benign and usually does not recur after excision. Another example of a benign vascular tumor that comes from lymphatics is a lymphangioma. This is another well-circumscribed collection of endothelial-lined spaces, but in this case, these are lymphatic spaces, so they do not have red blood cells inside them. They have lymph fluid, okay, and they can have some lymphocytes out in the stroma and the parenchyma. The main variants of a lymphangioma, there are simple lymphangiomas, which you can develop as an adult. They're just sporadic little collections of lymphatics. And you can also have cavernous lymphangiomas. Another name for a cavernous lymphangioma is a cystic hygroma, and this is associated with patients who have Turner syndrome. So here we're looking at a cystic hygroma in a patient with Turner syndrome. If you looked at this under the microscope, you would see these big dilated spaces. In this case, these are lymphatics because there's just fluid and no red blood cells in here, and you can have some lymphoid cells on the periphery. But again, completely benign, no endothelial atypia. Next, we're going to talk about a reactive vascular proliferation called bacillary angiomatosis. This is just a benign proliferation of blood vessels, and it is thought to be induced by infection, usually by Bartonella species. This is a gram-negative bacterium, which you may remember from POD. The two main subspecies of Bartonella that are associated with bacillary angiomatosis are Bartonella hensleyi, which causes cat scratch disease, and Bartonella quintana, which is also associated with trench fever. So this is associated, it often happens in patients who are immunocompromised, for example, in patients with HIV. And the clinical manifestation is this reaction of blood vessels produces a nodule, which is often red or purple in appearance. If we looked at this under the microscope, we would again see blood vessels. But in this case, we often have a lot of inflammatory cells in the background, usually a lot of neutrophils. You have some nuclear dust. And if you looked with special stains, in this case, this is a modified silver stain, a Warth and Starry type of stain, you could find these little bacilli, which are the Bartonella species, causing this problem. So it's often hard to actually culture this organism, but we can find it either with stains on the tissue or by doing PCR. And you can treat these patients with antibiotics, and this problem can completely resolve. Another sort of infection-induced problem is Kaposi sarcoma. Kaposi sarcoma is considered an intermediate type of vascular neoplasm because it can be very locally aggressive, and in rare cases it can metastasize. It is caused by the human herpes virus 8, HHV8. And there are 4 major variants of Kaposi sarcoma. In the United States, most of these cases are seen in association with AIDS, although the AIDS-related cases are now dropping because of antiretroviral treatment. In other parts of the world, a classic form of Kaposi sarcoma is seen in patients of Mediterranean, sort of Ashkenazi Jewish ancestry. Usually happens in older patients on the lower extremities, and it's thought to be related to suppression of T-cell immunity. There's the transplant-associated form, which happens, again, because of T-cell immunodeficiency after solid organ transplant. And this actually can resolve when the immunosuppressive drugs are stopped. Of course, then you face the risk of organ rejection. And then there is an endemic form of Kaposi sarcoma that happens in parts of Africa, which is just another subtype. And in this case, there is often also involvement of visceral organs and lymph nodes, and this can have a bad prognosis when it's spread out beyond the skin. So the clinical presentation of Kaposi sarcoma, these lesions often start out as kind of flat spots on the skin. They kind of have a red to purple violaceous hue, and they can happen anywhere on the body. The legs are common places, but they can happen on the trunk as well. They start out as these flat spots, which we call macules, and when these macules enlarge, we call them patches. They then can get raised into plaques, and then over time they get even more raised as the proliferation enlarges, and this we call a nodule. So once you're into a nodular stage of Kaposi sarcoma, the chances are pretty high that this patient will now get involvement of other organs and lymph nodes, and then the prognosis is not as good as if you caught it early in this flat macule patch stage. Under the microscope, we see slit-like blood vessels. Sometimes it's even hard to know that these are blood vessels, and all these spindly cells in the background are endothelial cells. We can prove that they're endothelial cells by doing stains like CD31 or von Willebrand's factor. In this case, we have some extravasated red blood cells. You can have lymphocytes and plasma cells out here as well. And really, the way under the microscope I diagnose Kaposi sarcoma is by doing immunostains. So in this case, we're staining for HHV8. And this is a nuclear protein which is being expressed by these cells. And this proves that this is HHV8-driven vascular proliferation and thereby Kaposi sarcoma. So the final vascular thing we're going to talk about is angiosarcoma. This is a true malignant neoplasm, meaning that it has the capacity to locally invade and metastasize. And angiosarcomas are common in older patients on sun-damaged skin, which is what we're looking at out here. But there is also a subtype that can happen after radiation of the breast, for example, in this patient. And another subtype happens associated with lymphedema. So in patients who have had a mastectomy, a radical mastectomy with lymph node dissection, they get chronic lymphedema, and they can develop angiosarcoma in that upper arm related to lymphedema. Another variant of angiosarcoma, which your book talks about, has to do with hepatic angiosarcomas in patients who are exposed to certain types of agents like polyvinyl chloride. But all of these angiosarcomas, when we look at them under the microscope, they can vary in their appearance. They can either be well differentiated or poorly differentiated, but they're all infiltrative tumors as opposed to hemangiomas, which are nicely defined and well circumscribed, and they have some degree of endothelial atypia. In this case, it's hard to even know these are endothelial cells, but these are the spaces, and these are epithelioid-looking endothelial cells. Again, we can do a stain to prove that these are endothelial cells, but because they look atypical, the diagnosis is an angiosarcoma. So next we're going to talk about some tumors of peripheral nerve sheath. A benign peripheral nerve sheath tumor is a schwannoma, and this arises from the surface of the nerves. It is often encapsulated. It can either be sporadic or it can be inherited. And in both of those situations, it's associated with inactivating mutations in the NF2 gene. You remember the NF2 gene encodes a protein called myelin, and myelin normally inhibits growth factor receptors from being expressed on the surface of the cell. So when you don't have myelin, you get more growth factor receptors that drive cellular proliferation and results in a schwannoma. In this case, we're looking at the forearm of a patient. This structure here is the median nerve. This tumor here is a schwannoma arising from the surface of the nerve, and this is the brachial artery. If we looked at this tumor under the microscope, we would see areas that are hypercellular, which we call Antony A areas, and hypocellular, which we call Antony B areas. And in the hypercellular areas, which is what we're looking at here on higher magnification, you get these nuclei that sort of palisade, and you have the central kind of neuropill area. And this is considered pretty characteristic for a schwannoma. They call these Verroque bodies. And then in the hypocellular areas, it's just sort of myxoid, and then you can get some hyalinized blood vessels. Schwannomas can be mitotically active, but they are completely benign. There is almost no chance of this transforming into a malignant tumor. The next sort of benign nerve sheath tumor we're going to talk about is a neurofibroma. And unlike a schwannoma, which was predominantly composed of Schwann cells, a neurofibroma kind of has a mixture of cells. It's got Schwann cells, but it also has perineural cells, it has fibroblasts, it has mast cells in it. It can also be sporadic, or it can be inherited, specifically neurofibromatosis type 1. So the variants that your book talks about include the superficial sort of cutaneous versions of neurofibroma, and these can either be solitary, which is usually what you see in just adults who have a single one of these kind of flesh-colored papules. This is not associated with any kind of syndrome, or you can have multiple of them. Usually when patients have many neurofibromas, and it's associated with neurofibromatosis. There can also be a diffuse form of neurofibromas in which you get a plaque and lots of these inside them. That's also more likely in somebody with neurofibromatosis. And finally, there's the plexiform type of neurofibroma. These two pictures are showing you a plexiform neurofibroma, and this is what happens. This is considered pretty pathognomonic for type 1 neurofibromatosis. And in this case, we have the tumor forming inside kind of the deeper nerves, and it's called like a bag of worms because of when you cut it out, it looks a little bit like a bag of worms. But it's essentially the tumor forming inside multiple nerve fascicles. It's a deeper lesion. If you have a patient with a plexiform neurofibroma, make sure you rule out type 1 neurofibromatosis. This is what all of these different variants of neurofibroma are going to look like under the microscope. Now, on the left-hand side of the screen, we're specifically looking at a plexiform neurofibroma, and I'm saying that I'm using the word plexiform to mean that this tumor is growing inside multiple nerve fascicles. So it almost looks like it's sort of encapsulated, and this is what's giving it that kind of wormy look grossly. But all types of neurofibromas, when we look on high power, are made up of these tiny little kind of wavy buckled Schwann cells. And they have what they call kind of shredded carrot-like pink collagen. You may have some mast cells in the background. Completely benign. Most neurofibromas do not turn into malignancy. However, the reason we pay special attention to the plexiform neurofibroma, especially in a patient with type 1 neurofibromatosis, is there is a small chance that this will turn malignant. So when it turns malignant, we call it a malignant peripheral nerve sheath tumor, or MPNST. These are pretty rare, except in the setting of NF1. Okay, so if you look at all of these MPNSTs, about half of them are sporadic, not associated with any kind of syndrome, but the other half arise from malignant transformation of these plexiform neurofibromas in patients with type 1 neurofibromatosis. MPNSTs tend to be poorly defined tumors. In this case, we're looking at this big tumor here. The clues to the fact that it may be a malignant tumor of peripheral nerve sheath are that the patient has type 1 neurofibromatosis or that the tumor is very closely associated with a deep nerve. Okay, and you know it's malignant because it will often, it's large and it often sort of infiltrates surrounding tissue. Under the microscope, there's really nothing specific about this. It's just sort of a proliferation of spindly cells. You can see lots of mitotic figures here. It is a malignant tumor. We can do some stains, but the clues are really clinical. The fact that the patient has this syndrome and the gross appearance that it's infiltrated, that tells you it's an MPNST. Here is a summary of type 1 and type 2 neurofibromatosis. I will let you read through this, but remember that type 1 neurofibromatosis has to do with loss of function mutations in the neurofibromin protein, which is a GTPase, right? And so in these patients, it messes with the RAS signaling pathway, as opposed to type 2 neurofibromatosis, which is a loss of function in that Merlin protein, which we talked about, its role in sort of growth factor receptors formation on the surface. And I'll just let you read through the rest of this chart. So here we're just looking at a pictorial representation of sort of some of the lesions associated with type 1 neurofibromatosis, multiple cutaneous neurofibromas, lesion nodules, which are pigmented hamartomas that happen in the iris, café au lait spots, which are these flat sort of macules that can happen on the skin, and axillary freckling. If you see all these things, think type 1 neurofibromatosis. Type 2 neurofibromatosis is often associated with bilateral cranial nerve 8 schwannomas, meningiomas, and spinal cord ependymomas. That brings us to tumors that we can't quite fit into any other category, both looking at it, doing these immunohistochemical stains, and doing molecular studies. We cannot put this mesenchymal tumor into any of the other categories that we've been talking about. In that case, we call it an undifferentiated pleomorphic sarcoma. The former term for this was a malignant fibrous histiocytoma. And essentially, this happens to just be the most common type of adult sarcoma that we see. Usually happens in the deep soft tissue of the thigh, and it's a very aggressive tumor, has a high potential for local invasion and metastasis. And you can see under the microscope, it just looks really bad. There are big, ugly looking cells, there's pleomorphism, there's mitotic activity, but the key is that we did all kinds of workup and we couldn't fit it into another category. That concludes our talk. Please let me know if you have any other questions. Thank you.